Hello everybody, my name is Slush Chow and I am currently completing my adult placement at Kingsbrook Jewish Medical Center. Over the course of my placement, I have had the opportunity to learn a lot with the trach and vent patients. For the purpose of patient confidentiality, I will refer to my patient as Mr. X during this presentation. Mr. X is a 90-year-old male. He was admitted to the nursing home at Kingsbrook Hospital with a medical history of hypertension, prostate cancer, status post pelvic lymph node dissection, and penile prosthesis. He has a history of AFib, vitamin B plus 2 deficiency with antiparietal cell antibodies, status post tracheostomy, and status post PEG. Prior to being admitted to the nursing home, Mr. X had a chest CT, which revealed multifocal pneumonia, most likely involving the lower lobes, and very small subpulmonic effusions. He also had a head CT, which revealed right cerebellar remote infarction, so meaning he had an old stroke, and ischemic white matter disease, and atrophy not typical for age. During Mr. X's time at the nursing home, we have been working on 3 goals involving swallowing and voice. I was able to conduct the speech and swallow evaluation on him initially and have been able to work with him in therapy over the course of my placement to work on his goals, which I believe are appropriate given his circumstances. And I will further discuss his goals and the therapy we've been doing later on in this presentation. So to start, I wanted to talk about the initial swallow evaluation that we conducted on him in the nursing home. Because Mr. X is a trach patient, during the swallow evaluation, the modified Evans blue dye test was utilized. So Mr. X was administered puree tinged with blue food coloring. Mr. X is oriented to person, place, and time. He has facial symmetry at rest, decreased labial and lingual range of motion and strength, and therapeutic trials of puree 2 times are provided via teaspoon tinged with blue food coloring. Mr. X refused subsequent trials despite maximal encouragement. And during the evaluation, it was observed that he had intermittent bolus hold, mildly prolonged bolus manipulation and formation with puree, increased AP transfer time, and trace amounts of oral residue noted post-swallow, which was cleared via oral suctioning. To talk about the pharyngeal stage, he had decreased hyolaryngeal elevation, which is secondary to his trach, and that was via digital palpation. His pharyngeal swallow trigger is suspected to be mildly delayed, and there were no overt signs or symptoms of airway protection deficits noted, so no coughing, no throat clearing, and he had no changes in his baseline vitals, so no drop in SpO2, no increase in heart rates. And it's important to note that Mr. X, he was on the vent at this time, and the mode was spontaneous, and he has a Chalet size 8 DCT with the cuff fully inflated at baseline. So during the swallow evaluation, his cuff was fully deflated, which he was able to tolerate. And I will talk more about cuff deflation and how it impacts the swallow later on in this presentation. So Mr. X was then provided with tracheal suctioning by an RN to see if any of the material was aspirated. And upon tracheal suctioning, no blue tinge secretions were noted. I also would like to point out that when using the modified Evans blue dye test, it's important that you only test 1 consistency a day. So during the swallow evaluation, we only did puree for today because if Mr. X were to aspirate, if we tested multiple consistencies, we wouldn't know which consistency he aspirated because they would all the consistencies are dyed blue, and when you suction them, if you see blue, you wouldn't know which consistency it is. So Mr. X was diagnosed with oropharyngeal dysphagia, and it was recommended that he receive skilled intervention to improve overall swallow function and tolerance of therapeutic trials for candidacy for the least restrictive diet. It also was recommended that for now he has continuation of MPO with alternative means. Evans blue dye test is a very popular method that is used to investigate swallowing. The Evans blue dye test is usually performed by placing 4 drops of 1% of Evans blue dye on the patient's tongue every few hours, and then the patient is suctioned to see if they aspirate their saliva. There also is a modified version of Evans blue dye test, which is a variation of this and uses food materials such as ice, liquids, or puree marked with blue dye. This tool is controversial, with some authors stating that modified Evans blue dye test has a lower diagnostic value than invasive procedures such as FEES or video fluoroscopy. Fiorelli et al. 2017 conducted a study to test the sensitivity and specificity of this test. During the study, 3 teaspoons of water were placed into the patient's mouth and they were asked to swallow. The cuff was completely deflated, and if the patient had NGT, it was removed for the test, which is important to note because we know that cuff inflation and NGTs can affect the overall swallow function. The trach was occluded with a speaking valve or by a finger to facilitate subglottic pressure increase during the swallow. So the patient was instructed to swallow using the blue dye. They were sectioned. It was observed whether or not blue tinge secretions were noted, and then they also had a FEES conducted on them 24 hours later. And the authors found that modified Evans blue dye test had a sensitivity of 85% and a specificity of 100%, meaning that in 7 patients, aspiration was seen on FEES, but it was undetected by modified Evans blue dye test. Whereas all 10 patients with positive modified Evans blue dye test, the results were seen on the FEES test. So area protection during oral feeding in tracheostomized patients is a very controversial issue. Some physicians start oral feeding without any hesitation and stop it when symptoms appear, while others are against oral feeding in almost every patient. However, both strategies are questionable because the first one could expose the patient to severe complications due to aspiration, while the second could limit a patient's return to usual activities. Therefore, a shared approach could be used to assess the presence of aspiration before starting oral feeding. So the authors point out that the modified Evans blue dye test could be a valid extra test to standardized examinations in clinical practice, which you can see summarized in the flow chart in figure 2 on this slide. So patients with negative modified Evans blue dye test should always undergo instrumental examination such as FEES or video fluoroscopy before starting oral feeding in order to 100% confirm the absence of aspiration. And then patients with positive modified Evans blue dye test, it can be a sign that the patient may need a PEG or NGT. They might need alternative means of nutrition, hydration, medication. So FEES and video fluoroscopy, they can be challenging procedures because they require particular skills of particular people, such as bronchoscopy and radiology. So using the modified Evans blue dye test can be an important screening tool to help us better evaluate the swallow function of those with tracheostomies. A speech evaluation was also conducted utilizing the Passy-Muir speaking valve. Mr. X, as I mentioned before, has a shyly sized 8 DCT with the cuff fully inflated at baseline, and you can see his exact vent settings in this slide here. During the evaluation, the cuff was fully deflated, and Mr. X tolerated the speaking valve for about 5 minutes without any signs or symptoms of respiratory distress. So for signs and symptoms of respiratory distress, we look for a drop in SpO2, a sharp increase in heart rate, excessive work of breathing. And he was diagnosed with aphonia secondary to trach, and it was recommended that he initiate speech intervention to improve overall respiratory flow and the tolerance of the Passy-Muir speaking valve. And the Passy-Muir speaking valve has a lot of benefits for trach patients, which I will also further discuss later in the presentation. So, regardless of the disease, the presence of a trach in anyone will affect the overall swallow function. According to Matthew et al. 2012, the presence of a cuff trach affects the pharyngeal stage of swallowing because the trachea is anchored to anterior neck tissues, which basically reduces elevation and anterior movement of the larynx. It can also uncoordinate laryngeal closure, esophageal obstruction by the cuff, or motor dysfunction, and can impair sensation. So, Matthew et al. 2012 found that increasing the cuff pressure in the trach influenced both sensory and motor components of the swallowing reflex. And the swallowing reflex was progressively more difficult to elicit with the cuff pressure increasing and resulting in motor swallowing activity that was depressed. So these findings suggest that peripheral mechanical constraints and centrally controlled inhibition may be involved in cuff pressure increase induced deterioration of instrumental characteristics of the swallowing reflex. So basically, if the cuff is overinflated, that can have detrimental effects on not only the structures but also the overall swallow function, because you have something there that's impeding their ability to safely and effectively swallow. So what is the passing ear speaking valve? So the passing ear speaking valve is a one-way closed position no leak diaphragm and can be used either with an inline vent patient, or it can be used with somebody who's on trach collar, and basically in that situation, the speaking valve just gets placed on the end of the tracheostomy tube. So the valve opens during inspiration and it seals shut during exhalation. And it directs exhaled air through the upper airways. So instead of the exhaled air coming out through the tracheostomy, it comes out, it will go through the vocal folds, through the mouth, and through the nose. And the trach must be cuffless, or if it's cuffed, the cuff has to be fully deflated. And that's because it's a one-way valve. So the cuff must be fully deflated in order for the air to be able to exit naturally through the upper airway. So there are many benefits of the speaking valve, which I'm going to discuss with you, but one of them is decreasing the risk of aspiration or laryngeal penetration. And although the passing ear speaking valve was developed to restore speech in patients with tracheostomies by directing expiratory airflow over the vocal cords, the passing ear speaking valve is marketed as a device that also improves swallowing and may reduce aspiration. And a study conducted by Alpern et al. 2000 found that use of the passing ear speaking valve can facilitate expiration through the upper airway after swallowing to decrease the risk of aspiration or laryngeal penetration. So in this diagram, you can see how the passing ear speaking valve works. In figure A, you see that there's no speaking valve placed. Inhaled air goes in through the trach, exhaled air goes out. In figure B, you can see the speaking valve placed, and you see inhaled air goes in through the speaking valve, but exhaled air exits naturally through the natural upper respiratory system, so through the mouth, through the nose. Okay. So as I mentioned throughout this presentation, there are many effects of a trach, which include tethering of the larynx, desensitization of the upper airway, impairment of vocal fold closure reflex, disuse, atrophy of the laryngeal muscles, loss of subglottic air pressure during the swallow. But there are many benefits of the speaking valve, which include improved breathing, swallowing coordination, restoring subglottic air pressure during the swallow, and decreasing compression by the inflated cuff. So Progent et al. 2012 conducted a study where they stated that the use of the speaking valve should be used to facilitate expiration through the upper airway after swallowing to decrease the risk of aspiration or laryngeal penetration. Okay, so finally, the goals that we've been working on with Mr. X, you can see they're listed here. There's 2 goals to improve his overall swallow function, and then there's a goal also regarding the passing ear speaking valve. So during skilled intervention, we've had Mr. X utilize effortful swallow, starting with puree and thin liquids to reduce his risk of aspiration. given his tracheostomy. So when patients haven't swallowed in a long time, it's important to have them practice swallowing itself. The effortful swallow is basically what it sounds like. It's having the patient swallow with a lot of effort or hard. So the goal of this technique is to use more motor units, increase the demand, and create a muscle training and strengthening effect. It is also used to protect the airway, which is appropriate given Mr. X's trach. And in This technique protects the airway when conditions such as head and neck cancer, stroke, or general deconditioning occurs, and the muscles of the tongue and the pharynx may not be able to do their part to push, lift, or squeeze to propel the food out of the mouth and the throat. The result of a weak muscle contraction is often that food or liquids pool in the mouth or the pharynx after the swallow. And after swallowing, residual food and liquid in the mouth and throat are likely to overflow into the unprotected airway and cause aspiration. So the patient is basically instructed to squeeze hard with all of your muscles as you swallow to increase contact between the base and the posterior pharyngeal wall while the patient is swallowing. And a study conducted by Takasaki et al. 2011 found higher pressures in the velar pharynx and UAS when using this method, which ultimately improved the overall swallow function. So I think this is appropriate for Mr. X considering the trach, and he has, reduced weakness. He has the trach in there, which basically affects his overall swallow function. So being able to, and that also changes the pressures within the anatomy of the larynx. So using the effortful swallow, I think, is a useful tool. Improving tolerance of the speaking valve, I think, is also an appropriate goal for Mr. X because it can not only help restore his voice, but as we mentioned before, the passing rate speaking valve tends to improve overall swallow function. And also, another important thing is that the speaking valve can be used as a process of weaning Mr. X off of the vent. So being able to tolerate cuff deflation and wearing the speaking valve for longer amounts of period of time indicates that Mr. X is restoring natural airflow and the ability to exhale naturally to the upper respiratory system without retaining CO2. And here are the references that I used throughout this presentation. Thank you very much.